Good morning. Myself, Dr. Rahul Patel, physiotherapist grade 2 since 9 years, UNMICR Institute of Cardiology and Research Center. Today, my topic is intercostal drainage, thoracostomy. What are the issues? When to put a drain, site of insertion, choosing the drainage system, clamping chest drain, time and method of removal, troubleshooting, understanding the chest drain. Let's see the image how to insert the chest drainage, draining fluid from chest. Let's see the image, area of dullness, site of insertion, fifth intercostal space, an intercostal drain. Chest drain or pleural drain is a flexible plastic tube inserted through the chest wall into the pleural space. It serves to drain pneumothorax or effusion from intrathoracic space, restoring normal lung function. Two bottle method, one bottle antiseptic, second bottle from blood. Recommended tube size, pneumothorax for 8 to 14 French, pleurodesis 10 to 14 French, emphysema for 24 to 28 French, hemothorax for 28 to 32 French. Clinical indication and contraindication. What are the indications for chest drainage? Pneumothorax, pleural effusion, hemothorax, chylothorax, post-thoracic cardiac or esophageal surgery, thoracoscopy. What are the contraindications for chest drainage? Coagulopathy, pulmonary adhesion from previous surgery, disease or trauma, diaphragmatic hernia. Site of insertion. The selection of insertion site is critical for safety and efficiency of chest drain placement. Optimal positioning. The exact site is determined by the specific location of the pleural abnormality. However, the fifth intercostal space in mid-axillary line is the site utilized most often for general drainage. Clinical consideration. While historically it was believed that air required an anteriorly placed tube in the second intercostal space, mid-clavicular line, clinical experience confirmed that a properly sized tube inserted through the fifth intercostal line, mid-axillary line, drain air and fluid effectively. Safety warning. Caution must be exercised. A tube placed to medially carry a significant risk of injuring the internal mammillary artery, potentially leading to serious life-threatening hemorrhage. Insertion technique. Sheldon technique, blunt dissection, trocar, large bore, insert guide wire through introducer needle into pleural space, remove needle whilst maintaining wire position. Third, thread dilator over wire with twisting action. Fourth, advance chest tube over guide wire into pleural space, blunt dissection, trocar. large bore chest tube. For tube greater than 24 French requires skin and subcutaneous tissue incision large enough to insert finger into pleural space, avoiding or breaking down pleuropulmonary adhesion. Essentially, bedside ultrasound guidance marks entry point for all pleural effusion cases, preventing incorrect placement and reducing organ injury risk. Triangle of safety. Triangle of safety is the standard anatomical region for the safe insertion of chest drain to minimize the risk of injury to vital structure. Anatomical boundary. Anteriorly lateral border of pectoralis major muscle, posteriorly anterior border of latissimus dorsi muscle, inferiorly a line superior to horizontal level of nipple, apex toward the axilla. This region typically corresponds to 5th or 6th intercostal space in mid-axillary line, serving as the preferred site for safe pleural access. Principle of operation. Let's see the image. How to insert chest drainage, single bottle, double bottle. The system creates a one-way mechanism allowing air and fluid to exit the pleural space whilst preventing external entry. Underwater seal, distal tube and submerge in 2 cm H2O. Second, air drainage. Air exit when intrapleural pressure exceeds plus 2 cm H2O via pressure gradient. Third, fluid drainage. Gravity facilitates fluid drainage. Water position below the chest level prevent backflow. Recent preparation protocol. Explain procedure to patient. Obtain written informed consent. Accept emergency. Review the chest radiograph. Standard position supine at 45 to 60 degree angle. Slightly rotated with ipsilateral arm elevated behind head. Insertion site 4th to 5th intercostal space, anterior or mid axillary line within safe triangle through BTS guideline. Alternate patient. Patient tried most often for chest tube indicates supine or slightly rotated to appropriate site with ipsilateral arm over the head. Then a sitting position with the patient leaning toward the cardiac trolley. Alternative patient lateral decubitus affected hemithorax position uppermost may not be tolerated in massive pleural effusion. Seated position for loculated collection emphysema, physician standard behind patient. Monaldi position, second intercostal space, mid-clavicular line for pneumothorax cases. Material required. What are the material required for chest drainage? Let's see the material required for chest drainage. Sterile gloves and gown, skin antiseptic solution, example like Providone or chlorhexidine in alcohol, sterile drapes, gauze swabs, selection of syringe and needle 20 to 23rd gauge, local anesthetic like lignocaine 1 to 2%, scalpel and blade suture 20, silk instrument for blunt dissection, for cow clamp, guide wire with dilator if small tube being used, chest tube and connecting tube, closed drainage system including sterile water if underwater seal being used. Guide wire tube thoracostomy. Overview. This technique represents the most accessible method for chest tube insertion. It is typically performed under ultrasound or CT guidance, utilizing the Schrödinger technique with specialized guide wire and dilators for precise placement. Procedure step. First, preparation and access. Anesthetize the skin, periosteum and parietal pleura. Perform a small skin incision. Confirmation. Second confirmation. Insert an 18-gauge needle with a syringe into the pleural space, aspirating fluid or air to the confirmed proper placement. Third, guide wire placement. Remove the syringe and thread guide wire through the needle into pleural space. Remove the needle while maintaining guide wire position. Fourth, dilatation. Advance the smallest dilator over guide wire using a rotating motion. Then swap for the next size dilator to expand the tract as needed. Fifth, tube insertion and security. Thread the chest tube with inserter over the wire. Withdraw the wire, clamp the tube, anchor with horseshoe steering suture, and secure with a tension-free skin suture and sterile dressing. Trocar tube thoracostomy. Procedure overview. Initial incision. Perform a 2 to 3 cm incision parallel to superior border of the rib through the skin and subcutaneous tissue following local anesthesia. Trocar incision. Insert the trocar between the ribs into pleural cavity. Position the flat edge cavern to prevent damage to intercostal vessel. Safety control. The hand not applying force should be positioned next to the chest wall to control the depth of penetration. Tube advancement. Once the trocar is in pleural space, remove the stylet and insert the chest tube with its distal end clamp into pleural space. Completion. Removal the trocar to finalize tube placement. Alternate method. Use a chest tube with trocar position inside the tube. Disadvantages: more chances for puncturing lung and over vital organ. Operating tube thoracostomy overview. Most commonly practiced technique. Procedure step. First, administer anxiolytic 10 to 15 minutes prior to procedure. Use liberal dose of local anesthesia. Second, make a 4 cm incision in the skin parallel to intercostal space down to the fascia. Third, incise the fascia and spread muscle fiber using a blunt tip hemostat. Fourth, incise intercostal fascia above the superior border of inferior rib. Fifth, penetrate the parietal pleura using a blunt tip hemostat. Procedure step. 6. Enlarge the pleura hole using the operator's index finger. 7. Palpate the adjacent pleural space to detect potential adhesion. 8. Introduce the chest tube distal and clamped into pleural space using a hemostat. 9. Suture the tube in place using mattress suture as per PTS guideline. 10th. Clean the site and apply a sterile dressing. Chest tube placement. Safer insertion and advantages. Ultrasound guidance essential for precise entry, significantly reducing organ injury risk. Herdinger technique, minimally invasive approach leading to less trauma and faster recovery. Appropriate tube size, correct selection based on pathology, minimize discomfort and complication. Removal procedure and consideration. Timing, remove when drainage is minimal and air leak has resolved. Pain management, crucial to provide adequate analgesia before and during removal. Valsalva maneuver, patient exhale fully as tube is removed to prevent arthrogenic pneumothorax. Post-removal monitoring, close observation for recurrence or complication is vital. Let's see the image. Chest tube placement. Thyroid cartilage below trachea, heart and lung size. Let's see the section view. Fifth intercostal space, proximal and thoracostomy tube drained and advanced through incision into pleural space. Locally anesthetized area of insertion, infiltrating skin and tissue. Thoracostomy tube, suture and tape in place. Single port, Hopkins rod and lens telescope. Let's see the image. Single port. Single port thoracoscopy represents a significant advancement in minimally invasive thoracic surgery, utilizing a single incision to access the pleural space. Key consideration: Hopkins rod high definition visualization provided by advanced optic ensure precise anatomical identification. Chest tube placement, streamlines integration of drainage system through the same access point reduces post-operative discomfort and promote faster recovery. Surgical precision. The single port approach minimizes tissue trauma compared to traditional multi-port technique. Pleural drainage system, one-way Heimlich valve. Let's say the image outlet nozzle, rubber sleeve and inlet nozzle. Second image, let's see the airflow and sleeve closes preventing backflow of air. Third image, airflow and sleeve open allow to air to escape. One-way Heimlich valve. This drainage system is by far the simplest. Chest tube is attached to one-way flutter valve assembly which one constructed so that the flexible tubing is occluded whenever the pressure inside the tubing is less than atmospheric pressure and is patent whenever the pressure inside the tube is above atmosphere. When pleural pressure and pressure in the tube are negative, flutter valve is closed and no air enters the pleural space. When pleural pressure becomes positive, the tube is patent and air or fluid can egress from pleural space. One bottle collection system consists of one bottle that serves as both a collection container and a water seal. Chest tube is connected to a rigid straw inserted through a stopper into sterile bottle. Enough sterile solution is instilled into bottle so that tip of the rigid straw is approximately 2 cm below the surface of saline solution. Bottle stopper must have a vent to prevent pressure from building up when air or fluid coming from pleural space enter the bottle. When pleural pressure is positive, the pressure in the rigid straw becomes positive, and if pressure inside the rigid straw is greater than the depth to which straw is inserted into saline solution, air or liquid will enter the bottle and will be vented to an atmosphere or collected in the bottle. If the pleural pressure is negative, fluid will be drawn from bottle into rigid straw and no extra air will enter the system. Thus, the water in the bottle seal the pleural space from in or fluid from outside. One bottle collection system advantage and disadvantage. Advantages: easy to carry, works well for uncomplicated pneumothorax. Disadvantages: if large amount of fluid is draining from patient pleural space, level of fluid will rise in one bottle system and therefore pressure will have to be higher and higher in rigid straw to allow additional air or fluid to exit from pleural space. If the bottle is inadvertently placed above level of patient chest, fluid can flow back into pleural space. Bottle collection system: 3 bottle collection system and 2 bottle collection system. Let's see the image. The from patient trap the bottle, underwater seal bottle, and third manometer bottle, adjustable vent tube, and then connect to suction. Distance below the water is equal to negative pressure generated when suction is applied. Intercostal drainage system are critical medical devices used to evacuate air or fluid or blood from pleural space, restoring normal lung function. Advancement in technique and technology are continuously improving patient outcomes. Single port thoracoscopy advantages and technology. Less invasive, smaller incision lead to reduced pain and faster recovery. Hopkins Rod Lens Telescope provides superior high definition visualization of pleural cavity, improve outcome, enhance precision, reduce risk of complication. Drainage bottle system component and function. Collection chamber, suction control chamber, and water seal. The 3-chamber system facilitate one-way flow, preventing air from re-entering pleural space. The collection chamber gather drainage and the water seal act as a one-way valve, and the suction control the chamber regulate negative pressure for efficient evacuation. Clinical appliances. Clinical application: pneumothorax management, rapidly evacuate air to re-expand collapsed lung, pleural effusion treatment, drain pathological fluid accumulation, example like transsudates, exudates, emphysema, post-surgical drainage, essential for managing fluid and air after thoracic surgery, like lobectomy, video-assisted thoracoscopy surgery, intercostal drainage. Let's see the image. The pleura evac chest tube collection system collects the fluid in compartment C so that it does not spill into water seal compartment B. A patent chest tube should cause respiratory variation to be seen on the scale adjacent to compartment B, which measure intrapleural pressure. Compartment B also is the place to see bubbles if an leak is present. Water level in compartment A control intrapleural pressure and should be adjusted daily. Procedure protocol. Aseptic technique. First, sterile gloves, gown, surgical mask and drapes mandatory. Second, secure drain suture firmly in place, close three-way trap, dress site visibly. Third, connect system attached to chest drain tubing. Choice of drainage system. Cost, indication of chest drain, type of patient, water seal should be easily visualized, tube should be functional when no suction is applied, volume of collection chamber should be adequate, and marking should be such that drainage is easily quantified. Pop-up valve to provide safe if pressure built up in the system. Injection of material through chest. Injection of a fibrinolytic or DNA as in a patient with a loculated complicated parapneumonic effusion, tetracycline derivative or a different sclerosing agent through the chest tube in the patient with malignant pleural effusion. This is usually done by taking chest tube apart and injecting material through a tummy syringe. This procedure compromises the sterility of the system and increase the chances of pneumothorax. Securing drain. Matrix suture, 10 silk, complicated purse string suture must not be used as they convert a linear wound into a circular one that is painful for the patient and may leave an unsightly scar. A suture is not usually required for small gauge chest tube. Chest drain dressing. Large amount of tape and padding to dress the site are unnecessary and concern have been expressed that they may restrict chest wall movement or increase moisture collection. A transparent dressing allows the wound site to be inspected by nursing staff or for leakage or infection. An ornamental tag of tape has been described which allows the tube to lie a little away from the chest wall to prevent tube kinking and tension at insertion site. Clamping. A bubbling chest tube should never be clamped. Drainage of a large pleural effusion should be controlled to prevent the potential complication of re-expansion pulmonary edema. In cases of pneumothorax, clamping of chest tube should usually be avoided. Complication. injury to neurovascular bundle in the intercostal space, injury to lung parenchyma, injury to diaphragm, and consequent injury to intraperitoneal structure may occur. Injury to heart and other vessels, massive bleeding, re-expansion pulmonary edema due to rapid evacuation of fluid from pleural cavity, emphysema, skin excoriation and inflammation, subcutaneous emphysema and subcutaneous hematoma. Complication: malposition, incorrect tube placement, bleeding, hemothorax, vessel injury, lung injury, laceration, bronchopleural fistula, cardiac or vessel, heart and great vessel damage, abdominal organ, stomach, liver, spleen, bowel injury, infection, site of infection, emphysema, system issues like tube occlusion, diaphragm injury, other esophageal, thoracic duct, phrenic nerve palsy. This procedure is only done by cardiac surgeon. Chest tube physiotherapy management. What are the physiotherapy management for chest tube or thoracostomy? Assessment parameter like swinging, fluid rises during inspiration, negative pressure falls during expiration, less negative pressure. Bubbling, bubbles in underwater cell indicate air leak. Drainage, observe the volume and fluid color. Pain, assess the pain level regularly. Intervention, pain management like we applied TENS 20 minutes and cryotherapy for 20 minutes, appropriate analgesia, preambulation, positioning, early upright sitting, lateral side lying with operated lung uppermost, wound support, form gentle pressure around drain site, avoiding direct compression, deep breathing exercise, 5 breathe overly in 3 seconds and expiratory hold. Investigation, patient problem and management. Individual assessment will indicate whether gravity assisted drainage position are of clinical benefit. In some patients with very tenacious secretion, gravity is unlikely to help, and a comfortable position in which effective breathing technique can be carried out is likely to be most valuable. Let's see the image. Positioning of patient applied by physiotherapy: apical uppermost lobe, apical segmental upper lobe, then posterior segment right upper lobe, anterior segment upper lobe and lingula. Let's see the image. Right middle lobe, apical segment lower lobe, right middle basal and intralateral basal segmental lower lobe, anterior basal segment, lateral basal segment right lower lobe, posterior basal segment lower lobe. Let's see the physiotherapy management of thoracostomy. Mobilization protocol: begin day 1, sit on bed edge, progress to short walk, ensure drainage system upright, 0.5 cm below chest wall, start low, go slow, 3 to 5 minutes session, 2 to 3 times daily, check connection pre-mobilization, avoiding pulling tube. Exercise: Upper body active assisted range of motion shoulder exercise within pain limits 3 to 4 times daily. Scapula mobilization, inside lying, avoid shoulder abduction and external rotation initially. Lower body, non-resistant leg exercise, quadriceps, ankle, day 1 to minimize circulatory status. Emergency, if tube disconnect, ask the patient exhale fully, press the gauge against wound at end exhalation, call medical assistant immediately. Recommendation for safe practical chest drainage insertion. Let's see the image. Pneumothorax and chest tube insertion after re-expand the lung. BTS guideline for safe insertion. Site, safe triangle in mid-axillary line at 4 to 6 intercostal space. Second, imaging to be used during insertion. Ultrasonography guided insertion can be ensure safety placement. Fourth, do not use substantial force. Fifth, small bore drain to be placed under imaging guidance with a guide wire dissection. Sixth, blunt dissection for large tube before. 7. Chest X-ray available at the time of insertion except in case of tension pneumothorax. Anatomical overview. Following illustration provide a visual reference for the clinical procedure. Pneumothorax, collapsed lung, then second re-expanded lung with chest tube. Honorable gratitude and recognition. Thank you so much Dr. Chirag Doshi sir, who is the director of UNMICR Institute of Cardiology and Research Center, and thank you so much Dr. Aisha Madam, who is the head of Physiotherapy Department, UNMICR Institute of Cardiology and Research Center, and again thank you so much Photographic Department, and thank you so much who is the watch my video, peacefully listen and taking out precious time for this. Thank you.